I welcome you all to this session on cost of care. My name is Felix Masiye. I'm based at the University of Zambia. So quite a lot of the presentations we've had throughout the last 2 days lead us quite naturally to a discussion about cost. And a part of that, the motivation for that discussion is based on the fact that a number of people, both in government and outside of government, are seeking some accountability for health spending. We need to know how much it costs to produce what we're producing. But there's also a recognition, as we heard yesterday, that the level of spending is unlikely to keep pace with the increasing needs and demands for healthcare in many countries, especially in low-income countries in Africa and Asia. And so we seeking opportunities to identify efficiency gains where we can, and the beginning of that process is essentially costing, estimating the costs of care. But there's also, on top of that, a new movement, a global agenda about universal coverage, which is quite getting ground in Africa and in Asia. So this coming week, next week, there will be a meeting which the African Development Bank, the World Bank, the WHO, and others are convening in Lusaka to discuss financing reforms with a view to achieving universal coverage. And while I applaud the decision to hold the meeting where they have chosen to hold it, I don't particularly envy their job at this point in time. But having said that, I believe that the work that we're going to be hearing in this session will save the needs of that group and others working to understand the operational side of the healthcare system, and also to identify if we can improve the efficiency of our health systems. And so maybe we can get to the substance quite quickly. I would like to introduce the 4 presenters this morning and also announce a slight change to the order that you have in your folder. We will have Bruce Hollingsworth going first. And Bruce is a professor of health economics based at University of Lancaster in the UK. I think many of us know him during his time at Monash University in Australia. So he is director of the health economics unit at the University of Lancaster. And he will go first. And after Bruce, we will have Mike Hanlon, who is an assistant professor of global health at IHME. And he leads the work that IHME does on costing. So he will be presenting some work around costing in Africa and other parts of the world. And then after Mike Hanlon, we'll have Matt Snyder, who is talking in place of Mead, as you have it in your folder. So Matt is a co-author of the work that they have done on costing. And he is formerly an IHME PBF. He did his master's here as well. Then moved on to the Center for Global Development in Washington, D.C., and most recently has moved to USAID as HIV/AIDS costing advisor. And then last but not least, we'll have David Collins, who is a senior health finance advisor at Management Sciences for Health, also with vast experience in costing health programs. So I welcome the 4 presenters and quickly ask that maybe Bruce can get going. Thank you.
Thanks, Felix. Good morning. My name is Bruce Hollingsworth. As Felix said, I work at the newly formed Health Economics at Lancaster Centre, which is at Lancaster University in the UK. And I'm going to be talking this morning a little bit about where we should focus in this area in terms of cost, production, efficiency, and effectiveness. Well, as a health economist, I'm quite confident that I can say to you that costs of care on a macro level, on a large scale, are certainly increasing. Generally speaking, these include costs of treatment and prevention, all the things you would normally know about and expect. And a mantra that's often trooped out in a lot of conferences and at a lot of occasions is that increasing prevention should mean that treatment costs will fall in future. And of course, that's often true. Preventing disease A will hopefully stop at the cost of treatment for disease A in the future. But if you prevent disease A, whatever that happens to be, and people live longer, and don't get me wrong, I think living longer is a very good idea, then people often get different diseases. They'll get disease B, disease C, and the longer we live, often we'll get more complex illnesses. The burden of disease, burden of illness changes, and in fact, the costs of care may increase over time. So preventing something may stop the costs of one thing, but the overall, the macro costs of care for things may actually increase over time. And that's because the demand for care, as economists call it, demand for health care, is seemingly insatiable. As we live longer and as costs increase, this is becoming a real issue. Now, if we have a demand for something in economic terms, we often have a supply for something as well. Now, this is a diagram you'll have seen lots of times before, perhaps not with flags on it, but it's something you will recognize. Along the bottom, over the last 50 years, you can look at expenditure in healthcare, and up the side, yes, you can see the actual expenditure increasing in adjusted terms. Now, this is for rich countries, this is for OECD countries, and you can see as costs of care have increased, as life expectancy has increased, expenditure on healthcare is really increasing quite dramatically. Now, every data set has an outlier. You can see who that is, and I'm not going to talk about that today out of respect for where I'm standing. Now, I'm going to give myself two asides today from the presentation. Here's the first one. The yellow bars on this diagram, which show on the right, which show the EU countries, the yellow bars demonstrate increases in health expenditure in the 10 years preceding the global banking crisis of 2008. And what we can see is general increases in health expenditure over that term. The black bars here show how health expenditure changed in the 1 year following the global banking crisis. This is going to have knock-on effects throughout the world, I think, not just within the EU, within the rich countries. So that's my first aside out of the way. Here's another diagram that you might have seen before in one form or another. Economists are interested in the costs, but we're also interested in linking costs to some form of outcome. Here you can see along the bottom the amount of money spent on healthcare and life expectancy. Again, we're still sticking at the moment with rich developed countries. Do you get what you pay for in terms of costs of care and expenditure in care? Well, largely speaking, yes. The more you spend, the bigger the return and the longer you live for. Now, what's interesting here is, I think, that what economists like to do is split diagrams into quadrants. We love quadrant diagrams for some reason. So if you split this up, you can get more information. In the bottom left-hand corner, remember this is just rich countries, in the bottom left-hand corner, you've got your underfunded quadrant. Top left-hand corner, your more efficient quadrant in terms of cost efficiency, cost effectiveness, whatever you want to call it. Top right-hand corner, you've got something labeled effectiveness. You're spending a lot more, you're getting a little bit more for your money, which you should be. And again, all data sets have outliers, we're not going to go into that. But the interesting thing for me here, or one of the interesting things, is the movement from the underfunded sector to the efficient sector. By spending a little bit, a marginal amount of extra money, you can see dramatic gains in terms of life expectancy. And remember, these are rich countries who are spending a lot of money to start with. Now, although that's interesting, looking at rich countries is interesting, partly, there's vast inequality in terms of world healthcare spending. The rich countries here are to the right. The top 5% of countries in the world spend 10 times as much on healthcare than the bottom 50% of countries. And the bottom 25% of countries spend about 2% of the amount on healthcare. So given the costs of care and what you expect in terms of a return, an economic return on your investment, your expenditure, it becomes increasingly important to benchmark, to look at efficiency, to look at cost effectiveness across a variety of countries. Now, it would be nice to have a diagram of all of the countries in the world in a quadrant to see what's happening. So here's one. Now, I'd like to claim that I did this, but I didn't. It's from Gapminder, and if you want to waste a couple of hours of your time, go to gapminder.org and change the axis. There must be 100 options on each. And it's fascinating to look at over time, but here's one of their standard diagrams. Along the bottom, income per person, which is heavily correlated with health expenditure, and up the side, life expectancy. The quadrants here, you can see the thin blue line, hopefully, up from the bottom at around $10,000 of income, the average income per person of the world. Up the side, the other quadrant divider is the average life expectancy per person of the world, which is just under 70 years. If we stick with our labeling of before, just to give you a little bit more information before we do that, the size of the circle is population, and the color here, which hopefully comes across quite well, the color labels where you are geographically in the world. If we stick with our labeling from before in terms of what you get for your money, in the underfunded sector, no surprise that the African countries are in the underfunded sector. Interestingly, if you do this diagram before World War II, all the countries of the world are grouped down towards the bottom left-hand corner. So in just 75 years or so, there's been a large increase in terms of inequity, in terms of the distribution of the cost efficiency of healthcare in the world. But if we stick with what we're talking about, the bottom left-hand corner, the underfunded sector, top left-hand corner, the more efficient countries, you spend a little bit more, you get a big return on your money. Top right-hand corner is the diagram we looked at before, the rich countries in terms of their cost efficiency and the returns they're getting. In economic terms, what's interesting for me here is we can start to look at how we can provide more information to countries about how they can improve their performance. And to take an example here, and to hopefully segue a little bit into what Mike and others are going to say, if you take a couple of countries here, if you take, for example, Zambia and Kenya, I think two of the countries Mike's going to be talking about, they spend a similar amount on care, but they have much different outcomes in terms of life expectancy. Now, there's lots of reasons for that, but if you look at these countries, and Ghana as well has an even bigger increase in terms of life expectancy. If you look at these countries in terms of 20 years ago, they still spent the same amount, but they had the same life expectancy. Now, obviously, there's a lot going on if you're going to benchmark these countries against each other. There's disease profiles, disease prevalence, age, sex distributions, health system differences. But in terms of benchmarking, if you've got accurate data, you can perhaps look at these countries and look at them and say, well, if you're spending these scarce resources in different ways, here's what the health outcomes are going to be. Can you learn from each other in terms of what's being spent and the health outcomes that you can gain? And you can do that in the different sectors across the diagram like this. Of course, this is done before. It's been done before. The World Health Report in 2000 took all the countries in the world and looked at the production of health and how efficiently they produced their health. That threw up several interesting things. It threw up that you should compare like with like in terms of benchmarking, and it also gave us information about data, and something I'm going to talk about in a moment, which is if you're going to do something like this, the thing you really need is accurate data and information to be as helpful as possible. Here's my second aside. If you just look at the health sector, you're missing an awful lot, because the health sector is only one thing that impacts upon health outcomes. Things like schooling, things like housing, things like sanitation are often equally as important and are highly correlated with health outcomes, but of course you know that. Returning to the issues, in economic terms, what we're interested in is cost effectiveness or cost efficiency, or however you want to label it. At the margin, we're interested in changes in costs related to changes in effects, and we're interested because of opportunity cost. If you've got a pot of money, you can only spend that once on certain things. If you spend it on one thing, you can't spend it on something else. So that information is crucial. Changes over time are crucial. Snapshots of efficiency aren't really much use to anyone. They don't tell you where you've been and where you're going. If we have changes over time and we have accurate data, we can benchmark to, again, provide more information as to how you can be spending your money more efficiently and more effectively. Metrics are important. We need standard measures, and we need to throw the best methods possible at those measures if we're going to be benchmarking in statistical terms. All of those things depend on one crucial thing. They depend on data. People need incentives to collect accurate data to provide information. If the data aren't accurate, if the data aren't good, the information that's provided is useless. Before you compare between countries, you need to know what's happening within countries. Same rules apply. If you're looking at efficiency of a system of hospitals within a country, you still need accurate data, good metrics, and good methods for comparing. And you need to look at changes over time to get the most out of that. You need to assess different groups in different ways. Again, this is a little bit of a twist on a diagram you'll have seen a lot, especially if you've done an economics course. Depending on what you spend, you get a diminishing return for your money in health terms. So rich countries spend an awful lot and are on the flatter part of the curve, so they get less return for spending more money in terms of life expectancy, for example, but they're interested in things like quality of care. Middle-income countries are moving towards the top of that curve. If you think about our four-sector diagram from before, they're moving through efficiency into effectiveness. Low-income countries are still on the slope of the curve. You still get a big gain from spending a little bit more in the right area. And that's why things like this and benchmarking against the right groups and having accurate data are so super critical. Why is all this important? Well, no matter how much money you've got, healthcare budgets are limited. Demand for healthcare is not limited. Countries have efficiency usually as one of their stated objectives in healthcare systems, and lots of NGOs also have it as their stated objective as well. Evidence. Well, I'm not going to concentrate on this a lot, but I can send you a paper. There's lots of evidence in it if you're interested. Efficiency measures. We're not talking about cost effectiveness, but we're talking about efficiency and benchmarking now. It's starting to be done a lot more in low-income countries, and there's still a lot of issues in terms of why this information perhaps isn't as useful as it might be. So what can we do in terms of measurement, in terms of translating the information that we generate into useful information? Well, resources are scarce, and that is a compelling argument to measure efficiency. There's lots of critiques of measuring efficiency and efficiency in terms of delivery of care in low-income countries. It implies sometimes budgets are sufficient. So does there need to be a threshold above which efficiency can be measured and mean something? Thinking back to the last diagram, for low-income countries, is there a point on that curve above which you can meaningfully measure efficiency and compare those countries between each other? Can we do more? Is some information better than nothing? Well, yes, I think we can do more. If we have standard metrics, excellent data collection, and people need incentive to collect data and keep collecting it accurately over time, then yes, we can do better. Things need to be context-specific. Metrics need to be relevant, reliable, and valid. Efficiency is just one part of a framework for measuring performance. We need to bear that in mind. There are equity issues, and there are geographical access issues, and other things which are equally as important. If you measure the efficiency of a system of hospitals in a country and decide that a hospital is operating inefficiently, it makes no sense to close that hospital if it's 500 kilometers and a 3-day walk to the next hospital. So there's more to life than efficiency. There is work underway, but can studies be more useful? Well, I think yes, they can. On Monday afternoon, a lady stood up, I think from Kenya, and said, please can you tell me where I can get cost-effective information which can help me in terms of making policy-relevant decisions? And across the room, those of us who worked in the area, there was a collective looking at our shoes because we didn't know what the answer to that question was. Can studies be more useful? Yes, I think they can. If we collect better data, give people incentives to collect data over time, use the best methods, have great metrics, then I think I'm optimistic we can provide better information which can really make a difference in terms of health outcomes. And I'm hoping this morning, and I'm confident that we're going to see some studies which are really moving the process forward and helping us out in this area. So for a copy of the paper on that this talk is based upon, the two papers this talk is based upon, please send me an email or go to my university research website, and thank you very much for your time.
Good morning, I'm Mike Hanlon. I'm an economist at the Institute for Health Metrics and Evaluation. And today I'm going to share some data and results on the production and cost of health service across 4 African countries: Ghana, Kenya, Uganda, and Zambia. I want to begin by addressing a misconception about costing analyses. I was in Geneva last week and I saw a presentation on the cost of providing immunization services in a developing country. And on the very first slide, the presenter had listed a number of services and the average cost for each. And he said, "This is the average cost data we collected in the field." Now, the problem with this statement is it was incorrect, and I think it's important for us to appreciate the nature of his mistake. When we visit a health facility, we can observe inputs, expenditure, and output. And from those observable variables, we can calculate cost and efficiency. When we describe, or we let people describe cost as data, we're obscuring 2 important points. The first point is that it's an estimate, and we need to be clear and transparent about how we generated that estimate. The second thing that we are obscuring, and I think this ties to Bruce's talk a bit, we're obscuring that these 2 unobservable variables may be co-determined. And if so, we need to think about them at the same time. We can't think about one without thinking about the other. Put another way, if a health facility produced a very simple, homogeneous product and it operated at 100% efficiency, then any number of accounting rules would be sufficient to calculate the cost. But what if health facilities are producing multiple products of varying quality, and health facilities moreover vary with respect to the efficiency of their inputs and outputs? In which case, simple accounting rules aren't going to work. They're not going to tell us truth. We're going to have to rely on statistical inference to estimate these 2 variables together. This begs the question of how much inefficiency actually exists in African health systems today. At the extreme, there's 2 potential answers to this question. The top picture shows a ward from an overcrowded facility in Kampala, Uganda. You'll notice that there's a small number of staff serving a relatively large number of patients. In fact, there's more patients than there are proper beds. Now, this facility has lots of issues with its operation, but from a costing analysis perspective, it's not inefficient. The lower facility shows a picture of a hospital ward in Durban, South Africa. Now, this is a facility, a large hospital, that is paying staff and has other sunk costs that they're not using because there's no patients. Now, the nature of some of the expenses is that you either use it or you lose it. And if this is the situation you're in, it has strong implications for the costing analysis. So now, the question that we've asked ourselves as we've pursued our analyses is which of these pictures reflects reality in Africa today? And I'm aware of anecdotes and some academic literature that supports the top picture, the story told by the top picture. The problem is, I'm aware of other anecdotes and a separate academic literature that supports the second story. So which is true? Now, the problem with anecdotes and much of the academic literature today is that they're based on very small samples. If I only visit one health facility, my perception might be skewed. That's a problem with the literature today, that it's based on small samples. And it's a project that we at IHME and others have been attempting to solve. Our attempt to do that is a project that we call Access, Bottlenecks, Costs, and Equity. I'll refer to it by its acronym ABCE. And it's a project to collect the data needed so that we could estimate the cost of care and identify the constraints and bottlenecks to providing service. Now, for the countries in which ABC operates, the first thing we do is collate all the existing data provided by health ministries and other agencies. But a fundamental truth about health systems, especially in Africa, is that lots of data series are not aggregated up the administrative chain. So if you want to understand the health system, you have to go to individual facilities. We do this via a facility survey, and at a sophisticated facility, we will collect thousands of variables about that facility's operation, many of those data series over 5 years. Excuse me. Now, of course, collecting lots of information about a small number of facilities is insufficient. So for this project to work, we have to go to lots of facilities. And in all the countries in which operate at the facilities, the samples we've gone to have both been large and diverse. The table lists the 4 African countries in which ABC is operated and the number of facilities from which we have successfully collected data. The map shows the distribution of those facilities in Ghana, geographic distribution. Now, in terms of the number of facilities, these include everything from large national referral hospitals to small clinics and even private pharmacies. So what does the data have to show us? This is an example from Ghana. It's a scatter plot of 2 descriptive statistics for Ghanaian facilities which offered inpatient care. Each dot on this figure is a specific individual facility for the year 2011. The x-axis is the number of beds at that facility. The y-axis is the occupancy rate. We've calculated the occupancy rate by the number of bed days reported by the facility divided by the number of beds times 365. There are 2 horizontal lines. The lower represents a threshold of a 50% occupancy rate. The upper represents a threshold of 100%. Now you'll notice in Ghana, in 2011, 15% of the facilities in our survey reported an occupancy rate at or above 100. So those facilities look like the picture up top of the crowded Ugandan facility. However, 52% of the facilities reported an occupancy rate between 50 and 100. And a third of the facilities reported an occupancy rate below 50. In Ghana, you'll notice that there's a positive correlation between bed size and occupancy rate, although that doesn't generalize across countries. So what do we see across countries? These bar charts summarize those scatters for all 4 countries. Ghana is represented by the blue bar, Kenya is in red, Uganda green, and Zambia in purple. The leftmost collection of bars represents the facility level average occupancy rate. In Ghana, it's 62%. Uganda is the next highest at 46%. And Kenya and Zambia are both at 38%. Now, in all 4 countries, there's a small number of facilities operating at or above 100%. But those averages get driven down, especially by the number of facilities that are operating with occupancy rates below 50%. You'll notice that that is illustrated by the rightmost set of bars, and that rate's lowest in Ghana, and then much higher in Kenya, Uganda, and Zambia. In fact, we're at 75%. So this figure clarifies that there's an awful lot of heterogeneity within a country. And if we're going to estimate costs, heterogeneity with respect to the efficiency of care, the utilization of the inputs. So if we're going to estimate costs, we have to have a statistical model that can accommodate that variation. To motivate our statistical model, I'm going to look at the theoretical cost function for a moment. The x-axis in this function is the output produced by the facility. The y-axis is the expenditure. The intercept of the fixed cost that the facility has to bear, even if output is 0. And the supply curve represents the minimum expenditure necessary to produce output. So if a facility was perfectly efficient, it would be operating on the curve, as illustrated by the green dot. Yet what happens if the facility is inefficient? Well, in the context of a health facility, inefficiency has a super perverse effect because it reduces both output and expenditure. By definition, if I'm inefficient, I'm not producing as much output as I could be, given my expenditure. But because I'm not producing as much output, my expenditure may also decrease. Inputs like staff are a sunk cost. I can't have the staff person come back and work for free next period, but I may not bear the same amount of expenditure with respect to drugs or supplies. And this creates a very tricky econometric problem because we have 2 slopes to estimate. There's the efficient supply curve, which is the green line, and the inefficient curve, which is the red line. We need a statistical model to accommodate this objective of estimating 2 slopes. Fortunately, there is such a model. It was developed by Yair Mundlach in a 1978 Econometrica article. And what he does is combine random, between, and fixed effects. Economists call fixed effects the within effect, and so the Mundlach model is known as the within-between model. You'll notice the first 2 terms of the model on the right-hand side, beta naught and the gamma, represent the facility's group level average random effect. The third term, beta 1, is an estimate of the between effect. Beta 2 is an estimate of the within effect. Think of it as the fixed effect. And this ties to our theoretical model in the sense that beta naught is our estimate of the fixed cost of providing a service. Beta 1 is an estimate of the supply curve. and beta 2 is an estimate of the inefficient curve. Now, if a facility is inefficient, as on the previous illustration, it's operating on the red segment. Because it's already bearing so much expenditure, it can add output at a very low cost. But once facilities hit the efficient part of the curve, adding output's now very costly because you're on the green part of the curve, which is steeper. And it seems that looking at the real data, this is what we find. Now, I need to stress before I talk about the numbers, these are very preliminary results. There are literally dozens of issues to work through in pinning down a specific econometric model. And we're in the process of working through that right now. That said, I think these results have something interesting to tell us. What we've done is model the total expenditure at the facility level as a function of its inpatient and outpatient services. We've aggregated all the different services they provide into one of those two categories. And there's one notable exception here that by total expenditure, we exclude expenditure on ARV pharmaceuticals. Had we included it, the outpatient numbers would be higher and more so in countries that provided more ART care. That said, and those caveats aside, let's look at these numbers and interpret them. So in Ghana, we estimate the between effect for inpatient care is $224 US, and the within effect is 238. Now those numbers are both statistically different from zero, but they're not statistically different from each other. So my interpretation is that on average, over the length of the data we've observed in Ghana, which was 2007 to 2011, facilities increased their output. But when they increased their output, they had to increase their expenditure. And as a result, Ghanaian facilities on average must be relatively close to the frontier. They're relatively efficient. Looking at Kenya, Uganda, and Zambia, we see much lower levels. The level of the numbers are lower, and that is principally driven to lower salary rates in those countries. But you'll notice looking at Zambia, for example, on the bottom, the average rate for inpatient care was $112 for the US, but the win estimate was not significantly different from zero. So what this means is over the length of the observation in Zambia, we see facilities increasing the amount of activity. We see them increasing the number of visits, but we don't actually see expenditure increasing in any detectable way. The same thing generally holds for our estimates of outpatient care, where the between estimates are significant and the within estimates are not. Now again, as we work through all the issues in an econometric specification, these results will change generally. But these patterns hold well enough to share with you today. One interesting thing, I think, is that the ratio of inpatient to outpatient care is between 5 and 17 in this sample, which is relatively high from what I've seen in the literature. But I think the key point is that many of the results in the literature aren't very clear about how they actually calculated costs from the data they've observed. The position that we have and what we've learned from this project is you absolutely must think about cost and efficiency at the same time. And the reason you have to think about them at the same time is because looking at our data, it's clear that both of these scenarios exist, and that variation complicates the econometric analysis tremendously. I look forward in the next few weeks and coming months to work through all our models and so we can be able to share both the data we've collected and the results with you. Thanks for your time, and I look forward to any questions.
Good morning. My name is Matthew Schneider. I'm pleased to be here today presenting this work that Mead over Teju Valajan and myself have been working on for the past year in collaboration with the Clinton Health Access Initiative, where we have been attempting to analyze policy-level determinants of HIV costs and then relate those to and the determinants also of these benefits of quality in sub-Saharan Africa. So something that has been driving our research and this question of policy that was raised by previous speakers is how can we further reduce costs in healthcare, such as HIV treatment, but not at the expense of quality, and that those cost efficiencies shouldn't be there shouldn't be much of a trade-off. We need to preserve that quality. So that's been our framing and our driving force behind this research. So we'll return to this at the end, but I kind of wanted to bring it out to help frame how we approached looking at these determinants and the quality, and we'll get more into detail here. But based on the analyses we'll go into in the following slides, we're able to identify facility-level determinants that relate both to cost and quality and a measure of quality for HIV treatment. Based on these estimates, we're able to categorize these determinants into areas like win-win, where we can see improvement in retention and reduction of costs, which sound like a win-win to me. We also then are able to also find determinants that look at specific, or are found to be related to reduction of costs, but not necessarily a reduction or an improvement in quality, and vice versa as well. And then finally, kind of the more difficult policy decisions are these trade-offs where we see a reduction in retention, a reduction in retention, but also a reduction in costs, and vice versa. So again, we'll come back to this at the end, but hopefully this kind of frames how we wanted to look at the determinants and ultimately try to apply those to the policies to make them as relevant as possible. Now for a quick outline of the rest of the presentation. I'll go through the description of our data, then our analytical framework, and the analysis of the costs and the quality, which in our case is patient retention as a proxy for that quality. And then finally some of our selected results, and conclude. So first for the data, the match study that I'm presenting here, or the multiple country analysis of treatment costs for HIV, was conducted for the 2010 costing year in these 5 countries across 161 health facilities, all focusing or having components of HIV treatment. And these costs are specifically captured for HIV. I won't go too much into the actual allocations of these costs, but we'll say that a bottom-up approach, so kind of an ingredients approach, where you can see prices of inputs and the utilization of those, was used to calculate these costs at the facility level. And also, unfortunately, we're not able to capture any costs above the facility level. So we don't see necessarily major technical assistance in those costs that are coming into this. So this is only focused on the health facilities. Needless to say, in each one of these 161 facilities that data was collected, it was a huge undertaking, and the Clinton Health Access Initiative their team spent 2 to 3 weeks at each facility and came away with about 10,000 data points per facility. And these ranged from cost data, obviously, as well as patient chart level data, which we utilized in the retention analysis, and then also qualitative data for personnel interviews and answers to specific questions that attempt to get at these policies that we're so interested in measuring their effects on costs and quality. So for a brief breakdown of the findings of the costs, across our 5 countries, you can see Malawi having the smallest average costs for HIV treatment at roughly $136 per patient year. While on the other side of the spectrum, you see that the Republic of South Africa, RSA, has a much higher cost per patient year, around $680. But in the first 4 countries, Malawi, Ethiopia, Rwanda, and Zambia, you see that over 50% at times is pretty consistently driven by the price of drugs. Whereas in South Africa, this is really a function of personnel costs being so much higher, as it is a high income country. Now, to the retention piece and our measure of quality, many measures were collected during the data collection period, where we try to get virological estimates, CD4 counts, but unfortunately, due to inconsistencies across all of the facilities and their reporting structures and ability to accurately collect these, we ultimately had to use retention as a proxy. Now, we also are able to look at, on average, 100 patient charts were collected from each facility, 50 trying to be new patients and 50 established patients. And the new patients are considered or classified as new if they had been initiated on ART at the facility not more than a year before or no later than 6 months after the start of the costing period, whereas established patients are considered established, having been on treatment for at least a year by the start of the costing period. We also aren't able to track transferred patients, so if those charts were collected, we unfortunately couldn't utilize that as we don't know their outcome. And then these two graphs show the separation. These are just purely descriptive statistics on the Kaplan-Meier curves of the retention over a year for the new and established patients. So strictly descriptive, but we'll get into how we approached analyzing these using a Cox proportional hazard later. So now that we have a bit of an understanding of the data, this was our analysis plan. We are able to look at costs, which are the gray in the top, and the retention pieces in the blue in the bottom. And we tried multiple econometric approaches to the costing piece. We tried stochastic frontier analysis as well as data envelope analysis, but pairing that with our finding and desire to look at both outputs of pre-ART patient years and ART patient years, we decided to go with a different approach, but where we weren't combining these two. And also because we found that antiretroviral drugs were often driven, and those determinants were so uniquely driven, different than all other facility costs, so equipment, personnel, other infectious disease drugs, treatments. We're able to separate those two out into two separate analyses, thus the two flowcharts there. And the retention pieces, again, we look at established and new patients. So, and using these functions and models we'll get into, we are able to look at putting those effects, an estimation of an effect of changing those policies and putting together a cost-benefit relationship. So getting into the cost functions. As I said, we looked at multiple ways of analyzing these cost analyses and creating a cost function, but ultimately we decided to go with this translog cost function, where we also look at we estimate a jointly shared equations, so of our price indices. We have 5, as I named, personnel broken into indirect and direct personnel, as well as other components. We also have our 2 inputs, ART and pre-ART patient years, in both the share and the cost function, and then also a complementarity between these two. So we wanted to look at, are there benefits to be made from having a pre-ART program with an ART program that I'll go into in a second. And also the factor prices that I was just discussing, which relate to the share equations that are jointly estimated using a seemingly unrelated regression analysis. And finally, our hypothesized determinants of cost variation that come from our data collection, and we will refer to as Z variables. And those are our costs. So really briefly, this is that complementarity of what we see in pre-art to art ratios. These are ISO cost curves where holding constant the costs, you're able to estimate for varying production points the output, and you're able to see that these curves are actually convex, meaning that there's some trade-off, but not a huge amount, and gains to be made at having pre-art and art in the facility. The red dots are actual data, and we see some of these major convex curves at the bottom due to, we think, because in the 2010 period, South Africa, which are the points that have no pre-art, often drive that data curve. And we also are able to find that for larger facilities, we see economies of scale. Now for the ARV costs, we did a little separately, as I said, due to the fact that we only need to look at one output, ART patient years. We're able to use, we don't have to fall back onto a translog cost function, but are able to look at the log of ARV costs predicted by and controlling for prices, ART patient years, and then our country effects and Z variables. So the Z variables are derived from this rich source of over 10,000 data points per facility. And from those, we're able to create about 80 or more hypothetically plausible variables that try to get at these determinants and policy level determinants that can hopefully give us insights into different changes that facilities can make on affecting costs. Because we have 80, we needed to use a stepwise approach to whittle this down because we didn't have the power, even using a jointly estimated cost function, to include all of them. And so stepwise allowed us to choose some statistically significant results or associated results and include those in our final analyses. And of course, as this is observational data, we really want to drive home that this is plausible associations, and we try not to cut off at the typical 0.05 or 0.1%, but also consider others at 0.2% cutoffs. So finally, our estimations and looking at the effects. Briefly, these are our Z variables after controlling for all others. We then estimate the effect of what happens if we went from the 25th percentile to the 75th percentile, or if, say, a facility is owned publicly or privately, if it is or is not. And so holding all other variables in that relationship constant, we make this change and then predict and estimate what the total cost would be, the change in those total costs. And we're able to do this both for ARV costs and non-ARV costs, and then ultimately summing those together. You'll notice that some indicators or determinants, such as the proportion of patients who bring a buddy to the facility, actually have opposite effects on costs, which is something that we see as a benefit of analyzing these two separately. So yeah, and for brevity, I'll go into the retention side. As I mentioned before, we use a Cox proportional hazard, where we look at prices as well as individual level data, the length of time somebody's been on treatment, CD4 at initiation if possible, WHO staging, and then of course we incorporate our policy level determinants to then ultimately be able to combine and have overlap between the policies that affect retention and also those that affect costs. And again, we see, as we estimated both established and new patients separately, we see again some policies act in opposite directions, and it's important to keep this in mind because as you add those together, sometimes those are lost and hard to relate to policy levels. But it's, and unfortunately, I don't have time to go into how we calculated all these, but I'm more than happy to come up and have a conversation about what each one of these different determinants and how they were calculated were done. And finally, we were able to combine these. So in our win-win category, where we see that costs are actually dropping, or we see that there's an indication, an association with lowering costs, though often, as this is hypothesis driving and observational data, we show things or effects that maybe wouldn't be the normal cutoffs. Mostly because we're hoping to continue a conversation and find out, these are interesting points and they should be looked into further, ideally with experiments. So in the win-win category, you see cost drop and retention improve. And then we have a cost-benefit ratio where and the negative signs can be interpreted as if you were to do this, you lower costs per patient retained. And so on. We have a lose-lose category, which is a little hard to understand, but since we estimated going from a 25th to 75th percentile, if you were to do the opposite, where you went from the 75th and dropped down to the 25th, these could also be considered possible wins, or win-wins, where you, in the lose-lose category, going from 25th to 75th, or 0 to 1s, you increase costs, but lower retention, but there's a possibility that if you were to reverse that, you would see the opposite effects. And then the trade-offs, the difficult ones that we see, increased costs, but also increased retention, or the opposite, where we see decreasing costs, but also some indication that retention is sacrificed at those costs. And finally, we return back to the slide where we're able to look at these different categories and compile those and hopefully have a good conversation with ideally policymakers and those who could carry this forward into experimental design to find out conclusively if this works. And finally, conclusions, some takeaways. We have our win-wins. We're finding that some dedicated facilities that focus mostly on just HIV versus more of a horizontal approach, they compared that with a high ratio of nurses to doctors, seem to improve retention, but are more costly. And those are some of the hard trade-offs and policy relevant questions that some people have to answer. And I think with that, I'll say thank you and acknowledgments to the MATCH team, all of the ministries of health that have been working so diligently with us, and Mike Hanlon for his input, and our colleagues at CGD, and the Bill and Melinda Gates Foundation for financial support and technical inputs. Thank you.
Oops. All right. It's a little too fast. I realize that this is the last session before lunch, so I not only have to keep you awake, but I have to try to prevent you from feeling hungry, which is going to be difficult. So luckily this is micro-costing, which is sometimes a little easier to grasp. So I will try to entertain. But on the other side of the equation, I think most of you are from academic institutions, and you maybe don't know a lot about an organization like MSH. So I'll take a few minutes to tell you about what we do. So we're a large non-profit. We work in more than 40 countries with funding from governments and foundations. Our main funder is US government. And I've been with MSH for 25 years, based in Boston, Kenya, and South Africa. We work in a number of healthcare financing areas on sustainable financing, social health insurance, performance-based incentives, financial planning and budgeting, and cost modeling. And I think what makes us a little different from some of the other people that are here was Joshua Salomon talked about on the first day about there being so many different cost-effectiveness analysis studies, but very few of them were used to influence policy. Our job in a country is usually to influence policy or to support policy decisions. So a typical thing that will happen to me was last year when the National TB Program Director in one of the countries said that I need a paper on the economic burden of TB in 1 month to influence resource allocation in the ministry. So I said, I don't think we can build a model to do that in 1 month. We don't have the data. And she said, no, we need it in 1 month. So we kind of do a mixture of costing art and costing science. So the science is where we collect real data, and the art is where we get what should be called expert opinion, but I think sometimes it's expert guesses. And we make a model around that, and that's the kind of work that we do. So we're under tremendous pressure a lot of the time to produce information for policy. One of the ways that we can do this is we use tools. So if we build a tool to analyze primary healthcare costs in a country, it will take us maybe 3 weeks to build it, but once we've built it, we can change all of the variables very quickly so that it can be used very easily for policy decisions. Now, we'd make them to be simple and user-friendly and transparent. So we make them in Excel, for example, and the idea is that not only do we use the tools, but we train people in the countries and we hand over the tools to them to use so that we are not the keepers of the tools eventually. Sometimes they become Ministry of Health tools. They adopt them and use them themselves. What kinds of tools do we have? We have integrated package costing at the community level, the health center level, and the hospital level. We have TB cost models. We have ICCM, community case management models, and social health insurance models. So it's a big area of our work that we're quite proud of. At the end of the presentation, you'll see the address of our website, and you can check them out there. So this one tool that I'm going to show the results from today is called Core Plus. And this one we invented about 20 years ago in Zimbabwe when the government funding, donor funding was being cut to family planning organizations. And the family planning organizations were supposed to become independent. So they came to us and they said, we need to know the costs and we need to know how much we should charge as user fees, because at that stage, insurance was not an option. So we checked out a number of health centers, and the first problem that we found was that they were doing things wrongly. So if we took the expenditures that they were making at their health centers and we built cost models on that, we would be costing inefficiency. So we changed the way we do things from then. So we went on to standard costing, where basically we take the norms for services, treatment norms, and we cost the treatment norms, not what they're actually doing. So this enables us to calculate the cost of services as they should be provided. And that's the kind of basis for most of our models these days. It's micro-costing, as I mentioned before. We use incidence and prevalence rates to estimate the numbers of services needed for full coverage, because a lot of the work we do is answering the question, how much will it cost us to scale up to full coverage? So we need the incidence and prevalence rates for that so that we can build them into the model. Then we have the expert groups who determine the normative costs, and they will say, for example, this service should be provided by a midwife and it should take about 30 minutes to provide the service. So that is what we will use as part of our standard costs, together with these are the drugs the midwife should use and the tests. We only use recurrent costs because mostly we're aiming to match the figures with government budgets or NGO budgets, and most of those are separate between capital costs and recurrent. We also build in revenue data. So for example, in Zimbabwe, it would allow them to calculate the cost for each service, but then also to model the user fees against the services so that they could find a way to balance, cross-subsidize where needed to be. Then we use an actual actual data from a sample of facilities to validate the standard model that we've built. And the results I'm going to show you are from those samples. And finally, the model has coverage targets in it, so that if, for example, it's covering 50% of the population now, and they will not be able to get to 100% next year, we can enter an intermediate target of 60 or 70% and see what that will cost. This is just the method, which is fairly simple, at least in theory. We get the unit cost for each service, as I mentioned, who's going to provide the service, how long will it take, what is the salary of the person, what drugs would be used, etc. We multiply them by the quantity of each service, and that gives us the direct cost for a facility. And then we allocate the indirect costs across each service using direct labor costs as the method. And that gives us two measures. We have a unit cost, a cost for each service, total cost, direct and indirect, and we have the total cost for the facility. This is probably the only way really to break down the costs of a health center, where you have a total expenditure, say, of $100,000. They provide 60 services. There is really no other feasible way to split the costs over the individual services, because the only other method that you could use would be timesheets, where a nurse is writing down, I spent 20 minutes on an HIV/AIDS consultation, which is obviously not feasible at all. So these are the services from the 6 countries that we've looked at. They're different time periods, so we're not really comparing across the countries so much as just looking at some of the differences. As you can see, the number in the first row, the numbers of facilities in the sample are quite low, because the purpose of this is not to determine the cost for the country, but rather to validate the model itself. But it does turn up some interesting comparisons. So if you look on the second row, normative numbers of services in the package, that is the number of services that should be in the package, which in the case of Cambodia is 48, but actually there's only 34, which means they're not providing the full package of services. Could be that they don't have the resources, or that people don't come to the facility for those services. So in many cases, as you can see across the board, when we're talking about packages of services being delivered, in many cases, they're actually not being fully provided. And then if we look at the actual versus the normative numbers of services in the package, we can see that those percentages are reflecting those, and they're less than 100. Let's look at the services per capita. If they apply the full package and everybody uses the services, again in Cambodia, there would be 2.81 services per person per year. And you can see again, looking at the row underneath, or rather the row on the bottom, that percentage-wise, nobody's operating at anywhere near full coverage. The highest was Rwanda at 67%. I think this is a very interesting slide. So if you look here, again, let's look at Rwanda, the second block. In Rwanda, this is cost per capita in US dollars. So the cost on average for the services provided is just over $6. And if they do the full package, the third column in green, it would be about $13. What is really interesting is that the red column shows that they are not spending enough on the current level of services. So the blue line, the $6, is what they actually spent, but they should be spending close to $8. This means that the current level of services are underfunded before you even start to think about how much will it cost to scale up. This shows the mix of services. You can see quite a bit of variance. And this will vary a lot, for example, with salary levels or with numbers of people. So if you look at the bottom line, which is the green blocks, Malawi, that is 22% compared with Rwanda, which is 48%. The difference can be that Rwanda has more staff in the facilities, but it's also partly that they pay higher salaries. So that changes the mix of the expenditures. If we look at the type of service that they provide, deliveries or preventive or curative. You can also see a mix in expenditures there. So Haiti, for example, is spending the least on curative and the most on preventive. So this is also a useful breakdown. This is taking one country and looking at what they spent versus the second row, which is what they should have spent for the same number of services, versus the third row, which is what they should spend if they scale up to 100%. And this is done by program area. So if you look, for example, at communicable disease control, they spent $3. They should have spent close to $4. But if they go to 100% coverage, they would be spending $8. They would need $8 per capita. So on average, only 3/4 of the services are provided and only half of the need is met. And this is not, in a sense, a future package because non-communicable diseases are actually not even included in there. The facilities need to increase their expenditure by half just to provide the right number of resources to ensure quality for the existing package. And they need to triple the resources to provide full coverage. So I think the question here is when we talk about scaling up to provide universal health coverage, should they be concentrating on improving the quality of the existing services, or should they be focusing on the scaling up the coverage level? And if it's not all affordable, where should the focus be? Should it be on, as I said, quality scaling up, or on communicable diseases or MNCH? Some of the costing challenges. Incidence and prevalence rates are not always available. The packages are not always clearly laid out, so it's hard to determine what the contents are. Lack of agreement on treatment norms, utilization data poorly recorded and incomplete, and actual expenditure data often incomplete. So, for example, the cost of drugs and supplies received or donor inputs which are not valued. And credit to my colleague Zina Jarrah and the others on here, and that is the end of my presentation. Thank you.
Thank you, everyone. So we're ready to take a few rounds of questions. So just walk to the nearest microphone, introduce yourself, and pose the question. Right, you may go ahead.
Hi, Bethany Kaposhi, University of Alberta. My first question is for Michael. Did you at all compare bed occupancy to staff vacancy? Any sort of relation to what the staffing levels were for the beds that were there, as well as bed occupancy in these large facilities related to the strength of primary health care in the region or the country? Also for Matthew, sorry, I can't see you very well. I was in South Africa when Clinton Health presented the findings of their study to the Eastern Cape Department of Health. And at the same time, we had done a study that we're currently working on publishing that showed the number reported on treatment in these large facilities. The difference between the actual number on treatment and the number reported was 36%. So they were over-reporting who they were treating. But I believe Clinton Health used the routine data to do their costing. So if you could sort of talk about the implications of that, if the routine data used for costing is incorrect and that is not checked when the costing is done, how does it follow through? Thank you.
Thank you. You may go ahead.
Hi, I'm Andrew Farlow. I'm on the Malaria Atlas project at the University of Oxford. I'm the sort of economist on the team. In very, very resource-poor settings, there's an awful lot of use of the informal sector, family networks, sort of improvisation. How is that, as a general question, I'm interested in how this is picked up in and how you control for it in your data when you're looking at data that's all about health centres or data that's actually recorded. There's an awful lot of resources used that aren't kind of recorded. Similarly, related to that is, and picked up by the last speaker, in very resource-poor settings, there's a lot of use of resources that's unnecessary, misdiagnosis, and lack of diagnosis means you try things out. So how is this captured in the way in which you handle your data? Thank you.
Okay, I think we can take a couple from...
Yeah. I'm Dr. Krishan. I'm a clinician from Base Hospital, LPT, Sri Lanka. Thank you very much for giving us a fabulous presentation, and accept my congratulations all for presenters. My question is on third presenter. I think I hardly see your name, David Collins, I think. So I'm had the 4 questions. My first one is, you have spoken about the regression of that intervention that you have done. So I just want to know about, is it multiple logistic and linear regression method? Which one that you have used for that, for analysis of your program effect, as I use for my intervention? So which one? Is it multiple logistic or linear regression? So kindly tell us the formula that you have used and the value, and is it used repeatedly for your program? Thank you.
Did you get the question? Excuse me, could you just repeat the question? I think we missed it somehow, so apologies. I'm not sure.
Usually, to assess the program effect, we are using multiple logistic and linear regression method. My question is, which one that you have used, and what is the formula you have used for that, and what is the value? And the last question is it repeatedly used for your program? So by using that, we can see the effects of the program. Thank you.
Thank you so much. Yeah, you may go ahead.
To follow on the first question, my name is Ellen McLaughlin. I'm from ITech, University of Washington. In a lot of these countries in Africa, there's human resources crises in the facilities. And I'm curious if in any of these models, whether a fully staffed facility are these modeling masking what the cost would be if the facilities are fully staffed with physicians and nurses and all the required personnel?
Thank you.
Hi, I'm Michael Freeman from IHME. My question is for Mike Hanlon. Near the end of the analysis, it seemed like Ghana was the best performing. It was closest to the frontier. But is that really where you'd prefer to spend a night in the hospital? And if not, is there a metric of quality that we can incorporate into the analysis? Or how can we couple reporting your analysis with some other qualitative measure or surrounding information about quality of care?
Thank you. I think we can ask the panelists to respond to those questions. Anyone?
I'll jump in. If I understood the first question, it was, did we relate the bed occupancy to staff absenteeism? Which I think the word was vacancy. Yep. But we did not. We didn't feel that we collected reliable data on absenteeism. The problem is when you ask a facility administrator how often are the staff absent, you don't know if, I'm sorry, was that not your question? I see. We didn't collect the data that you're asking about. What your question made me think of, the data we did collect that I think is really interesting, is we looked at what was the ratio of bed days produced to the medical staff at the facility, and we compared that you could think of that as a descriptive statistic of productivity, and you could compare that to the number of outpatient visits. Now, facilities, for whatever reason, will face a trade-off among us. The same medical staff can't do both. And so you would expect that there would be some frontier in that space. But what we saw from many facilities across all 4 countries was incredibly low ratios of both bed days produced at the facility per medical staff, and also at the same facilities, low rates of outpatient visits per medical staff. So I guess and then to jump into, I believe, the 4th question about the staffing crises, in our data, now my PhD is in economics, I'm the doctor that can't help you, but all I know is the data. And in the data, we see roughly 15% of the facilities across countries where they are slammed. They probably do have legitimate staffing crises at this facility. But there's many facilities from a third to more where we don't observe that at all. Mm-hmm. So that's what our data has to say. Yeah.
Thank you.
Thank you for the question. I had not heard that these 2 competing findings were out there. But if that's the case, there are definitely ways in which, if there's an undercounting or overcounting, of people who are on treatment, obviously that would drastically change the prices per patient, or the cost per patient, as well as possibly some of our retention findings based on when that loss to follow-up actually occurred. It would be really interesting to hear kind of your inputs. And we've actually run into something like this in Zambia with the UNGAS report, and being able to align some of the findings which were more specific to established patients, that our numbers were underestimates of the attrition, mostly due to patients who have been in a facility or lost and are older. Those charts were thrown away, and we were able to, based on some relationship between the two, try to weight estimated patients that we find would be more related. So there could be something in those lines. It would be interesting to talk more afterwards. Thank you.
Okay. On the health center work that we've done, I think we've seen understaffing. We've also oddly seen overstaffing, particularly in urban areas where people would rather be there and they're politically connected enough to work there instead of having to go to a place that's 300 miles away. So distribution's an issue. The way our models work is that they calculate using the minutes, as I mentioned before, how many staff you actually need in a facility. So we can say from that, you need 5 numbers for this volume, 5 nurses for this volume of services. You also have services provided by the wrong level of person. So for example, there isn't a doctor at the facility, but there should be, and it's actually a nurse that's providing the services. We've also found some interesting things in the urban areas, like in Johannesburg, where a solution to one of their problems was to take one of the staff that was dedicated at one center and share her across 5 centers. This was for psychiatric services. So I think the way that staff are used is quite inflexible, particularly in government. And so I think people need to look more carefully at how you can schedule patient services.
In terms of the informal care, I think that was an excellent question, and it's a critical point. It is accounted for in a lot of economic studies, not looking at health, the health center level of effectiveness and efficiency, but looking at intra-household level of care. And it's important, I think, because it has knock-on effects outside the health sector. It can have effects in terms of education. For example, if children are the ones who are the informal carers, their education suffers if they're not able to go to school because they have to undertake the informal care. That has impacts upon the productivity of the society in future, and you end up in a vicious circle where it's hard to get out of the situation that you're in, and that applies a lot in areas such as HIV, for example. So that work is undertaken, but again, it's finding the data and finding the information. It's very hard to collect that data, and it costs a lot of money, and provision of data like that in the informal care sector, I think, is almost as important as looking at the efficiency at the large-scale macro level. So I think that is something that is critical, because it has effects outside the health sector that come back into the health and productivity of society. So good question, thanks.
Thank you. I think there was another question.
One question. I addressed Mike Freeman's question about the quality of care. And if you'd permit me to restate it, I think what Mike's asking is what's optimal? Is Ghana better than Kenya because we estimate it to be more efficient or using its resources more productively? And I'd say this is not a cop-out, but it is completely outside the purview of an economist to answer that question. And our job is to say, given the data that we have, what do we think is true about the world? Are the Ghanaians happy with the level of quality in their health care, or is it degraded because the system is too stressed? That's their call. But our job is to quantify what's the current state of the world with respect to the productivity and the efficiency and the cost.
We still have a few more minutes for maybe another round of questions.
Hello, Diego Ríos from the Mesoamerican Health Initiative, and I have two questions for David Collins. The first one is, what we have observed generally in hospitals is that to provide a service, they are not missing the whole package, but maybe, for example, the anesthesiologist. So how does this impact the cost structure of the service provision? And then the other question is, what happens when norms fail to reflect reality? For example, that we have a huge hospital built in an area that doesn't have enough people to serve. And how do you account for this? Thanks.
Hi, I'm Sarah Pallas, Yale School of Public Health. And Dr. Hollingsworth, you mentioned the need for incentives to encourage accurate data collection, but as Dr. Hanlon mentioned, it's not just an issue of data collection. In this case, there's also the estimation. And I'd just be interested from the point of view of the different panelists, how to work around the capacity building challenge of not just the data collection, but also building the estimation capacities. So we heard a little bit from David Collins about some of the MSH tools specifically, and it sounds like Match was conducted in collaboration with Ministries of Health. ABCE, I'm not sure to what extent that was the case, or if it's really designed as a pilot, as an academic look. But can you speak a little bit about how to build this kind of cost analysis, both the data collection and then the resulting estimation, into something that's more routinely done by local stakeholders? And just related specifically to Match and ABCE, I'm curious about the overlap in Zambia. Was there any collaboration or coordination between your two projects, and what might we do kind of thinking systematically going forward about when we're doing these kind of very intensive 10,000 data points at the facility level, what kind of burden that imposes, and is there any way to kind of capture that cadence and share it in ways across initiatives? Thank you.
Hi, I'm Rachel Nugent here at the University of Washington. This question is for Mike. Mike, in presenting your look at the link between efficiency and costs and developing your algorithms around that, you gave us the example of patient bed days, which is fairly straightforward, I think, to measure in terms of utilization and so on. Can you give us a couple of other examples from the other types of facilities that you're looking at, how you're measuring utilization or whatever your metrics are in relating those metrics to costs, for instance, pharmacies?
Thank you. You want to go first? David Collins, I think the first question was for you.
Yep. Talking about the health center level, because the hospital is obviously much more complex, how we deal with missing staff there is a tricky one. So for example, if a health center should have a doctor, but it doesn't have a doctor, so there's a lower level of person doing that work, where if the standard is to, if the norm is to have a doctor there, we would cost the services as if there is a doctor there. That is the standard normative costing. When we compare that with the actual work that's done and the costs, obviously if there's no doctor, the costs are much lower. But lower cost doesn't mean more efficiency. In this case, it means a drop of quality. So, we are really calculating the cost of the resources that are needed to fulfill the goal of the health center with the norms that it has. And that's, we don't, for example, look at outcomes of the health center. That would also be beyond our work. It's a tricky one, because part of the question is if there's, for example, a senior nurse providing services that a doctor is supposed to be providing, then you're running into problems with the health services in general. So it's a tricky issue. We use our models. Many of the times they raise questions more than they provide answers, but they're questions that need to be raised. In terms of the next question was the norms do not reflect reality. Well, that's exactly the point, I think, why we use the norms, because when we compare the cost of what they should be doing with what they're actually spending, that completely highlights that reality is different from norms, and that's one of the ways we do that. So that's part of the work, and that's what we intend to do. The question of, if I understood it correctly, was making the costing routine. There's not a huge amount of success with that for a couple of reasons. The skill sets in the ministries are not terribly good around doing costing, typically. They have finance people, but they're really budgeters, accountants. They're not people who are good or even trained to do modeling. One solution to this that we've started to come up with in Rwanda and Indonesia is that we actually train people from the universities to do this kind of analysis, and then they are available as local consultants to assist the ministries of health. We would recommend that the kind of costing tools are used annually, not more frequently, because it's not supposed to be a costing system. It's supposed to be a kind of annual appraisal and moving forward. The best success we've actually had is with the family planning affiliate in Guatemala, who actually created a whole department around this, and they've been doing annual costing and using that again to set fees, to do advocacy with donors, and they've been very successful. With governments, it's more difficult, but I think using the universities is a good approach.
Mike, you want to speak to the last point?
So regarding the question about the incentives to collect data, in addition to the 4 countries discussed today, we've data collections ongoing or complete also in Lebanon, Colombia, and 6 states in India. And in all of those cases, the principal partner has been the Ministry of Health, the National Ministry of Health. But in every case, we've had a local partner, often an academic partner. So in the case of Zambia, it was the Department of Economics at the University of Zambia. In the case of Ghana, it was the Ghana Health Service, some local partner that actually runs the project on the ground. And the incentives they've used to collect data have varied across countries. The cultural context is hugely important. My favorite example comes from Lebanon, where the partner on the ground was the University of American University of Beirut. And the PI would reach out to local community and religious leaders and say, hey, we're trying to conduct this survey in the hospital, and the hospital administrator is not cooperating. Could you please, on behalf of AUB, reach out to the facility administrator? And that was hugely effective in that setting. I would defer to Felix, who could discuss about how it worked in Zambia, or other collaborators who are here to talk about how it worked in their country. But I've been frankly shocked at our success to get data out of facilities, especially private facilities across countries. So there's local knowledge about how to do this, and people are highly effective. Regarding the routinization of the data collection, I don't think it's feasible to think that there's ever going to be a health management information system where we're getting thousands of variables from these facilities year after year after year. And I think one of the outputs of this analysis is for us to identify what are the key variables you need to have to understand the efficiency and the cost of providing care. And truthfully, as we've learned as we've gone on in this project, the variables that we thought were the most important always turned out not to be the case. And variables that we didn't really, we threw in almost without much thought have turned out to be hugely important. So I think the onus is on us to say this is the data that has to be collected routinely if you want to understand this problem. Oh, sorry. Do you want to deal with the overlap? So there was also a question about the overlap between the ABCE project and the MATCH study and potentially others. The country in which we both overlapped was Zambia, and we intentionally designed not to go to the same facility and ask similar types of questions. So it turns out there were, I believe, 4 facilities in which there was overlap, but by design we didn't. And I think that actually, in retrospect, we might regret that a little bit. And I think for other future studies, people have their own different academic objectives. You're asking different questions, and I think sometimes it might be useful if we had more overlap to try to relate our results.
Just to add one more thing, one of the biggest problems we have, particularly with hospitals, is tracking drugs. You can find out how much they paid sometimes for the medicines that come into the hospital, but where it's distributed within the hospital is very difficult to find out. The records are very weak, maybe sometimes intentionally. So it's very, very difficult to determine how many drugs are used in one department versus another department, and then trying to allocate those to patients. It's in most places I work, it's impossible.
Just a quick point about the excuse me, incentives to collect data. I think Mike made a great point about deciding what the minimum data set should be. And the incentive to keep collecting that is to show how useful it can be in policy terms and in helping out in terms of making decisions. That could be a key incentive in terms of continuing to collect and use the data.
So we've come to the end of the session. I would like to request you, ladies and gentlemen, that we can give a round of thanks to the four presenters. Thank you.